Hi guys, I hope I'm audible. So we started our Farre medicine yesterday, and from yesterday we learned about the respiratory medicine. We discussed few important questions, and I also shared the list of other important questions that is available on the MedEd's Farre section on the app. So today we will start with cardiology. Today and tomorrow we will have discussions on cardiology. We will focus on the important, conceptually little difficult questions. The simple questions you can read from the Farre notes as well. So the first question we have is on a valvular heart disease. Repeatedly asked valvular heart disease questions are mainly about aortic stenosis and mitral stenosis. Apart from that, heart failure, the constrictive pericarditis, cardiac tamponade, these are important topics from cardiology, and emerging topics include pulmonary embolism. Okay, so we'll start with the first question, that is on the aortic stenosis. The question might go like this: discuss the etiology, clinical features, diagnosis and management of aortic stenosis. Now, any valvular heart disease question, the first thing you should do is put a neat image depicting the position of the valve. Where is that valve position, between which chambers, and also mention the normal size of that valve. If possible, if you have a fair idea, mention in cardiac cycle where exactly this valve opens and where exactly this valve closes, and then start the discussion on the rest part that is asked in the question. If you don't remember, fair enough, at least put a sketch and mention where exactly the valve is located. So let us begin by discussing 2-3 minutes on the basic aortic valve anatomy, and then we will talk about aortic valve stenosis. So as we know, aortic valve is a valve positioned between the left ventricle. So if this is my left ventricle, this is my left atrium, and this is aorta, then the aortic valve is positioned between the left ventricle and aorta. The exact site of its location is called the root of aorta. So this part of the aorta, the initial part of the aorta, we call it as a root of aorta, and aortic valve is situated in the root of aorta. So first point to note, this is my aortic valve. This part where it is located is called as aortic root or root of aorta. And its objective, the reason why aortic valve is there is to allow the unidirectional flow of blood from left ventricle to aorta and not allow the blood to flow back from aorta to left ventricle. Now, its normal opened size. So just like any other valve, the aortic valve is made of a connective tissue ring. It is made of a connective tissue ring, and that connective tissue ring we call it as annulus. So it has an annulus or a connective tissue ring, and to that connective tissue ring the cusps or valve leaflets are attached. So examiners would be interested to know whether you know how many leaflets are present in a valve. So make it a point that you do write about the number of cusps present. So this part of the aortic valve is called as annulus. Annulus is a connective tissue ring which helps the cusps to hold on to the wall of the aorta. And then there are 3 cusps. We can number them as 1, 2, 3, or you can also call them as the right, left and non-coronary cusps. So these 1, 2, 3 are the cusps or leaflets. So aortic valve is a 3 leaflet or 3 cusped valve. Okay, and its normal orifice size when open. The normal orifice size is usually 3 to 4 centimeters square, and whenever the opening is less than 2.6 centimeters square, we will call it as aortic stenosis. We will call it as aortic stenosis. Okay, now what is the function of the aortic valve? As I just told you, the aortic valve should allow the movement of blood from left ventricle to aorta. So now one of you should tell me, when the movement of blood happens between left ventricle to aorta, is it during systole or is it during diastole? I'm discussing a little more on the valvular heart disease because this is not only going to be your theory question, but this is also going to be the questions that the teachers are going to discuss in your case presentation. So for a final prop student, of course, you need to know basic valvular heart diseases, right? So the blood moves from left ventricle to aorta during systole. Systole, we eject the blood. During diastole, we fill the ventricle. During systole, we eject the blood from the ventricle. So blood moves, yes, absolutely right. So if the opening of this aortic valve is narrow, is it going to disturb the diastole or is it going to affect the systole? Of course, the blood is moving during the systole. So if the opening is narrow, it is going to disturb the systole. So simple words, we can think of aortic stenosis as a problem of systole. The problem of systole. Okay, this much is clear. So with this basic introduction, we are talking about aortic valve stenosis. Normal opening is 3 to 4 centimeters square, less than 2.6. We are considering it as stenosis. And this stenosis is going to affect the systole of the cardiac cycle, because during systole, the blood moves from left ventricle to aorta. Okay. Now let us talk about the causes. Why this aortic stenosis happens? The causes wise, it is better if you mention the most common cause than the other causes. So the most common cause for aortic stenosis is age-related degeneration of the aortic valve. Just now I told you that the aortic valve is inserted into the root of aorta. And because it is in the root of aorta, it is not exactly in the left ventricle, it is in the aorta. The atherosclerosis that develops in the aorta also encroaches upon the aortic valve cusps. And the atherosclerosis of the cusps makes them get calcified. It's a natural aging process. And because of the calcification, the valve cusp becomes stiff and they find it difficult to open. In simple words, we will call it as age-related degeneration. More technical terms, we can say the problem begins with atherosclerosis. The problem starts with atherosclerosis of the aortic valve that eventually leads to calcification. And once there is calcification, you can call that stage as well as the aortic sclerosis. And once it starts creating the obstruction to flow of blood from left ventricle to aorta, we will call it as aortic stenosis. So this is a process, age-related degeneration. That also means that most of the patients of aortic stenosis are going to be elderly, not your middle age or young individuals. But we do see some young patients presenting with aortic stenosis. So in that case, what could be the cause? The most common cause in young individuals. The most common cause in young individuals is going to be having congenital. We just learned that there are 3 cusps in the aortic valve, but some people are born with only 2. We will call that condition as congenital bicuspid aortic valve. And congenital bicuspid aortic valve is the most common cause for the aortic stenosis in young individuals. So if you see someone in their 20s, 30s or 40s presenting with AS, it is most likely because of congenital bicuspid aortic valve. But if I see someone in their 70s or 80s presenting with aortic stenosis, it is most likely because of age-related degeneration. Congenital bicuspid aortic valve, usually abbreviated as BAV. If you can remember, also mention the most common cause, because it is congenital or inherited. Of course, mutations may be responsible. There are so many mutations responsible, but among them, the most common mutation responsible for this congenital bicuspid aortic valve is mutation in a gene called as Notch1. This is an important MCQ point as well for the MCQ based exams. Apart from this, various other conditions are considered as risk factors for aortic stenosis. You don't have to write it in a theory paper, but for your MCQ knowledge or for your bedside discussion, you should know. We just learned that atherosclerosis is the root cause. That is where the problem of aortic stenosis starts. Atherosclerosis eventually leads to calcification of the valve, and then you have aortic stenosis. So anything that increases the risk of atherosclerosis increases the risk of aortic stenosis. Smoking, yes. Diabetes, yes. Dyslipidemia, yes. Sedentary lifestyle, yes. So all the conditions that increase the risk of atherosclerosis are risk factors for aortic stenosis. Okay. Now these are the common causes you need to write. Now after the causes, let us say someone, he started aging, and because of aging, he has developed aortic stenosis. What symptoms he is going to present with? Just to make sure we understand symptoms well, let me begin with the pathophysiology. Exactly what happens when there is aortic stenosis. We just learned that the problem is mainly systolic. In the systole, the blood moves from left ventricle to aorta. But if the opening is narrow, the movement will be hindered. So let us say someone has developed aortic stenosis. Now, if someone develops aortic stenosis, I will find it difficult to eject the blood from left ventricle to aorta. So the amount of blood I eject from the ventricle to aorta in one systole, what do we call that amount as? The amount of blood ejected by left ventricle to aorta in one systolic contraction. We call that as stroke volume. And don't you think the stroke volume is partially dependent on the opening of the aortic valve? the valve is not completely open, will I be able to get a good amount of blood pushed out from the ventricle to aorta? No, the opening becomes a limiting factor. Smaller the opening, less amount of blood get ejected to aorta. So can I say aortic stenosis leads to decrease in stroke volume? Yes, perfectly right. We will have decrease in the stroke volume because of this aortic stenosis. So the first pathophysiological change we might notice is decrease in the stroke volume. Aortic stenosis leads to decreased stroke volume. Will it lead to some symptoms? If the stroke volume decreased, will it lead to some symptom? Yes. Stroke volume is very much necessary to perfuse the organs for their normal functioning. If stroke volume is less, the brain may not get sufficient blood supply. Your muscles may not get sufficient blood supply. Because muscles are not getting sufficient blood supply, patient loses his effort tolerance. They start getting fatigued easily. So fatigue is one of the symptom I can expect because of decreased stroke volume. Second, if brain does not get sufficient blood supply, I may go through episodes of syncope or syncope, as you would like to call it. So we can get fatigue and syncope. Well, we do expect hypotension because please remember your systolic BP is directly proportionate to stroke volume. Higher the stroke volume, higher is your systolic BP expected. But once the stroke volume starts decreasing, the systolic BP starts decreasing, but body has a counter regulatory mechanism, that is renin, angiotensin, aldosterone system, that will correct the BP. So most of the patients of aortic stenosis may not have hypotension at the time of presentation. Why they don't have hypotension? Because though we are dependent on stroke volume for regulating the BP, we have a counter regulatory system, that is RAS, which can elevate it. So you need not always have hypotension, but the RAS may not elevate the stroke volume perfectly. So because of that, you will continue to experience fatigue and syncope. So that is one set of symptoms. The problem is not over just because I got fatigue and syncope. Aortic stenosis is not all about fatigue and syncope. We can have other problems. What other problems? If I did not eject sufficient blood, if I start struggling to eject the sufficient blood, do you think left ventricle should keep quiet? Don't you think left ventricle would put more effort to try to eject the blood out into the aorta? The amount of work that left ventricle starts doing to push the blood through this narrow opening starts increasing, right? The workload on the left ventricle is increased. Now, can anybody tell me what kind of workload is this? What kind of workload is this? See, because in cardiology, we have two types of workload. One is called as afterload. The other one is called as preload. See, let us say this is my ventricle. Okay. It has to eject the blood up. Okay. Now, in this ventricle, I have 200 ml of water. So if I want to push this out, I need to do some X amount of work. But next time I add 400 ml. Do I need to do the same amount of work to eject the blood up, or I need to put more effort now? Earlier it was 200 ml. So to push 200 ml up, I had to put X amount of effort. Now it is 400 ml. I need to put 2X effort. So the amount of blood that is present in the ventricle before I start the systole is an important determinant of the work done by the ventricle, right? The more blood in the ventricle, more is the work that ventricle needs to do. Now this volume, we call it as end diastolic volume, because this much of blood is there at the end of diastole and we are about to start the systole. And this is there before I started the systole. So we will call this as preload. It is there before I started the systole. End diastolic volume is equal to preload. More the volume, more effort ventricle needs to eject. But once the ventricle start the process of ejection, do you think aorta is welcoming the blood? It's like, okay, de do mujhe blood, I need blood. No, it's a closed tube, right? If I have to blow air into the atmosphere, like imagine this is my ventricle, my mouth is ventricle, I'm blowing air into the atmosphere. I don't encounter much resistance. But what if I have a small tube and I try to blow air into that? I have to put more effort, right? Because the tube is going to resist the entry of air into that tube. Similarly, when left ventricle is ejecting the blood into the aorta, it is not ejecting into the free atmosphere. It is ejecting into a closed tube. Aorta is a tube. So aorta gives some resistance to that ejection. And ventricle's effort has to overcome that resistance. So more the resistance aorta gives, more effort ventricle has to put. So that resistance, we will call it as afterload, right? So for those who don't know, let me write some key terms that might help you for revision. So the first term is end diastolic volume, the amount of blood present in the ventricle at the end of diastole before I start the systole, and that is also called as preload. More it is, more the work done by the ventricle. Second, resistance by aorta and its branches for ejection of blood. For ejection of blood by left ventricle, we will call that as afterload. Now, normal circumstances, aortic valve opens completely. It is not contributing to this resistance. Only resistance comes from the aorta. This valve completely opens, so any resistance that comes, it only comes from the aorta. But now that the valve opening is narrow, don't you think it is resisting? And to overcome that resistance, ventricle has to do more work, right? So what is increased in aortic stenosis? We have increase in the afterload, the resistance for the ejection of blood, increase in the afterload. So aortic stenosis leads to increased afterload. Now you may be thinking, why sir is stressing so much of the physiology terms, right? You will understand when we discuss little more about the pathophysiology. Now, to overcome this resistance or increased afterload, ventricle does more work. And the nature of the muscle is that ventricle is muscle. Nature of the muscle is that more the work it does, more it grows. So it is going to develop a hypertrophy, left ventricular hypertrophy. But the left ventricular hypertrophy is of two types. The first type, we will call it as concentric, and the second type, we will call it as eccentric. So what is concentric hypertrophy? In concentric hypertrophy, if say, let us say this is the left ventricle and aorta I am looking at, this is normal size left ventricle, let us say. In concentric hypertrophy, the muscle mass gets added inside the ventricle. The outer dimension of the ventricle doesn't change much. It is as it is. If I look from outside, this chamber of the ventricle looks of same size, but inside the thickness is increased. We will call that as concentric hypertrophy. In eccentric hypertrophy, the muscle mass gets added outside. So if this is the ventricle we are looking at, the muscle mass gets added outside. In both the cases, thickness of the left ventricular muscle mass is increased. But in concentric, the outer dimension of the ventricle is not changed. In eccentric, the outer dimension is changed. It appears big. So increased preload leads to, you should note that increased preload results in eccentric hypertrophy. Preload means end diastolic volume. So if I have more volume inside the ventricle, to keep that volume I need space, right? So is it a wise decision for the nature to put the muscle mass inside if the volume of blood inside the ventricle is already high? So I don't want to compromise the cavity size. I will add the muscle outside. This is what we call as eccentric hypertrophy, because here the main problem was volume increase in the ventricle. But when the resistance by aorta or its branches increases, I don't have a volume problem. So then I can add the muscle inside. So generally when there is increase in the afterload, increased afterload leads to concentric hypertrophy. So now tell me, in aortic stenosis, what kind of left ventricular hypertrophy we are expecting? This is concentric hypertrophy, left ventricular hypertrophy. This is eccentric left ventricular hypertrophy. Yes. So in the aortic stenosis, because we have the afterload increase, the resistance by the narrow aortic opening increased, we develop concentric LVH. And what will happen to the volume of the ventricle if I develop concentric? It becomes small, and that will create problems for us. So that was very good. So it is going to result in concentric left ventricular hypertrophy. So it will create two problems for us. Number one, you have concentric left ventricular hypertrophy. Now the muscle mass is increased. Don't you think it needs more blood supply to survive? More the muscle mass, it needs more blood supply. So there is increased myocardial oxygen demand. Now this large bulky ventricle needs more blood supply. But then blood to the heart's muscle comes from where? Coronary arteries. And coronary arteries originate from where? Coronary arteries originate from the aorta. So if I'm not pushing sufficient blood into the aorta, do you think I'm pushing sufficient blood into the coronary arteries? No. So the decreased stroke volume also means that there is decreased coronary flow. There is decreased coronary flow. So on one side, there is less blood supply to the blood vessels because of low stroke volume. And on the other side, the heart's muscle wants more blood supply. So there is a clear mismatch between the demand of the myocardium and what coronaries are able to provide. And what symptom this can lead to? There is a demand supply mismatch. And what symptom we can expect because of this? Yes, the muscle will suffer through ischemia. And what is the symptom of ischemia? Chest pain, which is called as angina. So angina is one more symptom that we can expect because of the aortic stenosis. So syncope is one, angina is another. What else this concentric LVH can lead to? Now we just learned that concentric LVH means the left ventricular volume is reduced. And because of that, when I want to fill the blood into the left ventricle, right? Don't you think I will have difficulty to fill this ventricle? Because again, here Boyle's law comes into picture. Boyle's law says volume and pressure are inversely related. Volume and pressure are inversely related. So if the volume of the ventricle is reduced, what happens to the pressure inside the ventricle? Pressure inside the ventricle increased. And yesterday I told you that the fluids move from high pressure to low pressure zone. So already ventricular pressure, normally let us say this is ventricular pressure. Now I developed concentric LVH, ventricular pressure increased this much. Now to fill this ventricle, the pressure in the left atria has to go above that of the left ventricle. So left atrial pressure will increase. If left atrial pressure increases, we just learned yesterday as well that if pressure in the left atrium increases, eventually the pressure in the if the left atrial pressure increases, because left ventricular pressure became high by its volume decrease. Now to fill that, left atrial pressure has to go above that of the LV. So now to fill the blood from pulmonary vein to left atrium, the pulmonary vein pressure has to increase above that of the left atrium. And to move the blood from the pulmonary capillaries to pulmonary veins, the pulmonary capillary pressure has to increase above that of the pulmonary veins. So the problem, whenever it starts in the left side of the heart, eventually reaches the lungs. Here it will cause congestion of the pulmonary capillaries because of rising pressure, and that congestion will lead to a symptom which we call it as dyspnea or shortness of breath. So every time you talk about or write about left heart disease, one standard symptom you can write with eyes closed, that is shortness of breath or dyspnea. This also applies to mitral stenosis. If I have mitral stenosis, this opening is narrow, left atrial pressure increases, then pulmonary vein pressure increases, pulmonary capillary pressure increases, you have shortness of breath. So one symptom that you can write for all left-sided conditions is dyspnea, because left-sided conditions always lead to congestion in the lungs. Mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, and left heart failure. For all of them, dyspnea is going to be standard symptom. Similarly, if I have a problem on the right side of the heart, the pressure will build up in the right atrium that will lead to raised JVP, ascites, hepatomegaly. So those symptoms you can write for all right heart disease with eyes closed. Okay, clear? So now in the aortic stenosis, we are expecting the concentric LVH will result in increase in left atrial pressure. In a theory exam, you don't have to write step by step saying that left atrial pressure increase leads to pulmonary vein pressure increase, pulmonary vein pressure leads to increase in the pulmonary capillary pressure. You can just mention the left atrial pressure will lead to pulmonary congestion. Congestion of blood in the pulmonary capillaries. That's pulmonary congestion. And that can lead to a symptom, we call it as dyspnea or shortness of breath. So as we see here, we are expecting three symptoms, which you can remember with a simple mnemonic ASD: angina, syncope, and dyspnea. Right? ASD. So now that you know the pathophysiology, it's easy for us to write down the symptoms or clinical features. So symptoms or clinical features of aortic stenosis are angina, syncope, dyspnea. The mnemonic is ASD. And the reason I want you to remember it as ASD, because you can also say, sir, I can also remember it as SAD. When you have aortic stenosis, you become SAD. Fair enough, but ASD is the ideal way to remember it because that is the sequence of appearance of symptoms. The earliest to appear, earliest symptom is angina, and late symptom is dyspnea. So that's why if you have a patient of aortic stenosis for bedside discussion, case presentation, and the teacher asks which symptom suggests that aortic stenosis is very severe, you should mention dyspnea, because dyspnea appears quite late. Angina is the earliest symptom. Okay, so these are the clinical features. The mnemonic to remember it is ASD. So let me summarize what we have discussed so far. If there's a question on valvular heart disease, make sure you write at least 2-3 lines about the valve anatomy. That pleases the examiner, that he will know that you're not giving a mugged up information, but rather you're giving a core clinical concepts. Okay, so then he will definitely give you half or 1 mark more. Then start with the causes. When we are talking about aortic stenosis, you have to remember only 2 causes for the theory exam. The most common cause overall is age-related degeneration, but in young individuals, it is congenital bicuspid aortic valve. In terms of pathophysiology, the narrow opening of the aortic valve results in restriction of movement of blood from left ventricle to aorta that happens during systole. So because of that, the stroke volume is less. Low stroke volume leads to syncope. And on the other hand, the narrow opening also creates more burden on the left ventricle to push. That increased burden is increased afterload, and increased afterload results in concentric LVH. The concentric LVH means that the more the muscle mass, more is the blood supply demand, which cannot be met because of low stroke volume. So we end up with angina as a symptom. Second, with the concentric LVH, the left ventricular volume decreased, and by Boyle's law, anytime volume decreases, the pressure increases. So once the LV pressure is high, left atrial pressure has to be higher than that to fill it. So eventually, every chamber behind it in the hierarchy starts developing increase in the pressure. It reaches the lungs, and in the lungs, it causes pulmonary congestion, whose symptom manifests as dyspnea or shortness of breath, giving rise to these 3 standard symptoms of ASD: angina, syncope, dyspnea. Angina is earliest, dyspnea is last symptom to appear. Okay. Apart from that, you can expect one more manifestation in patients with aortic stenosis, which is called as Heyde syndrome. What is this Heyde syndrome? It's a triad of 3 manifestations. The first one is calcific aortic stenosis, which is the most common cause. Means age-related degeneration leads to calcification of the aortic valve, and that causes stenosis. Young individuals, it is bicuspid aortic valve. But this Heyde syndrome is seen in patients with age-related aortic stenosis. Calcification of the aortic valve results in something called as acquired von Willebrand disease. Von Willebrand disease. Now you may be wondering, what is this acquired von Willebrand disease? So you may be knowing that there is a factor called as von Willebrand factor. This factor is present in the subendothelial space. So if this is a blood vessel, the innermost lining is endothelium, and just behind the endothelium we have these von Willebrand factors, which acts as platelet receptors. Every time there is injury to the endothelium, the von Willebrand factors get exposed, and because platelets have the receptors to bind to these von Willebrand factors, they will come and bind. That is how we achieve the platelet adhesion. The von Willebrand factor is responsible for the platelet adhesion whenever there is injury to the blood vessel, and that helps us preventing the blood loss. But then in the calcific aortic stenosis, what happens is the von Willebrand factor, which is in circulation, when it is passing through the aortic valve, it hits that calcified aortic valve. And when it hits the calcified aortic valve, it gets fragmented, because von Willebrand factor is a large molecular weight protein. And when it hits the calcified aortic valve, it gets broken down into tiny fragments. And those fragments are inactive. So you're producing the von Willebrand factor. You don't have any genetic problem, but that von Willebrand factor is getting destroyed by the calcified aortic valve, and every ml of blood has to pass through the left ventricle. So most of the synthesized von Willebrand factor is getting exposed to aortic valve, and it is getting broken down. So it is getting inactivated. So this condition we will call it as acquired von Willebrand disease. And many of us may have some arteriovenous malformations in the GIT, where micro injuries keep happening, but the platelet adhesion prevents further blood loss. But now that I have acquired von Willebrand disease, I may not be able to prevent bleeding in those GIT areas, and I end up developing gastrointestinal tract bleed. So when these three things come together, we call it as Heyde syndrome. Not seen in all aortic stenosis patients, but at least few of them may develop it, right? So ASD plus Heyde syndrome. This is all you need to write about clinical features. Now coming to the examination findings. So be it your bedside discussion or be it theory paper, for all valvular heart diseases, the assessors are expecting three information on examination. Number one, you should be able to mention what is happening to pulse and blood pressure in each valvular heart disease case, because in some cases the pulse pressure becomes wide, in some cases the pulse becomes feeble, and there are some named findings. Second thing they're expecting is you should mention what is happening to the apex beat on examination. This is commonly asked in your bedside discussion. Third thing is murmur, right? So first let us talk about the BP. In aortic stenosis, we expect the BP to be low. Why we are expecting the BP to be low? Because the stroke volume is low. But then, as I have already told you, the RAS counters it and you will end up getting normal BP. It is because the low BP is countered by the renin-angiotensin-aldosterone system. Some patients may have relatively lower systolic BP. You are not going to get them to have a fully elevated systolic BP. You may get on the lower side of the normal. When it comes to pulse, remember when you are palpating for the pulse comes and hits your finger, right? How forcefully it hits, that is dependent on the stroke volume. The peak of the pulse, if I have to put a waveform of the pulse, it has a peak, right? This peak depends on the stroke volume. It is directly proportionate to stroke volume. So lesser the stroke volume, peak becomes smaller. Further less the stroke volume, peak becomes smaller. So pulse, that small peak of the pulse is called as anacrotic pulse. Anacrotic pulse. It is nothing but a small amplitude or small peak pulse. In mild to moderate aortic stenosis. Mild to moderate aortic stenosis. Yes, the common day-to-day conversation for this small amplitude pulse is feeble pulse. The technical term is either you can call it as pulsus parvus or anacrotic pulse. It is also called as anacrotic pulse or pulsus parvus. Parvus means small. Amplitude is small. Then one more thing you have to remember, when I'm ejecting the blood from left ventricle to aorta, and that ejected blood volume is deciding the peak of the pulse. The more I eject, more I push into the aorta, I will get a stronger pulse. The rate of ejection also matters. Means the peak of the pulse depends on the volume, but the rate of ejection decides after how much time the pulse started, the peak will be hit. Means, let me give you a picture so that you can understand. Let us say I get the peak of the pulse normally like this. This is a normal pulse, normal peak. So from the beginning of the pulse, peak is achieved at this timeline, right? This much time is taken for me to reach the peak. Now, I developed aortic stenosis. Let us say it is mild. So then my peak becomes smaller, but peak comes at the regular time. But if I have severe aortic stenosis, I'm ejecting the blood into the aorta very slow. So then my peak becomes smaller and peak comes late. So it is small as well as peak has appeared late. So this kind of pulse is called as pulsus parvus et tardus. Parvus means small. Tardus means slow. So peak is small and peak appears late or appears slowly. It is called as pulsus parvus et tardus. This is something that during bedside discussion, you teachers are very much fond to ask if you have a case of aortic stenosis. They will ask what is pulsus parvus et tardus. So you can say it's a small amplitude, late peaking pulse. Small amplitude, late peaking pulse. Amplitude is small and the peak appears late. Pulsus parvus et tardus. This is encountered in severe aortic stenosis patients. In severe AS patients. Okay, I'll explain again. So basically, when we see pulse is what? Pulse is a pressure wave that travels through the aorta and its branches. And who is the reason for this pressure wave to appear? It is the left ventricle ejecting the blood. So when left ventricle ejects some amount of blood, let us say I started a systole and from the left ventricle I ejected the blood into the aorta. So suddenly pushing the blood into the aorta triggers a pressure wave. That pressure wave travels along the aorta and its branches, and that is what we are feeling as the pulse. So if I eject more blood, I will have more stronger pressure wave triggered. So I will have more forceful pulse. So when I measure this pulse in terms of pressure, I get a wave somewhat like this. Then it has a peak. The peak depends on the volume of blood ejected into the aorta, and we call that volume as stroke volume. So the peak, how tall the peak is, depends on the stroke volume. In aortic stenosis, stroke volume is less, so peak becomes smaller. Second, after I start the systole, when will I reach this peak? Whether I will take, like, let us say I have taken X amount of time to reach this peak, right? This is the peak. To reach the peak, from the beginning to this peak point, let us say I have taken X amount of time. But if I have severe aortic stenosis, the blood that is coming into the aorta is very slow because the opening is small. So it takes more time for me to reach the peak. So the peak will not appear on the regular time. The peak will become small as such, plus it will appear late. So it has taken now X plus this Y amount of extra time. So the peak now is small and late. That small peak late pulse is what we call as pulsus parvus et tardus. Parvus means, remember, small. Tardus means slow. If you have just completed your second year, you might know that you come across side effects of some antipsychotic drugs called as tardive dyskinesia. Dyskinesia means abnormal movements. Tardive means slow. So those patients have slow abnormal movements. The word tardive or tardus refers to slow. So peak appears very slow and it is also very small. That's the meaning of pulsus parvus et tardus, and that is seen in severe aortic stenosis patients. Okay. So after this, let us also talk about the auscultation findings. We will go to the examination, Nurse Shakir. There we will discuss about the ECG findings as well. Okay. Now on auscultation, we are going to get, I forgot to mention about the apex beat, because this is what routinely we ask in the bedside discussion. What is expected in pulse, what is expected in BP, and what is expected in apex beat. So apex beat generally gets shifted. What is apex beat? Apex beat is the only part of cardiac contraction that can be felt externally. Means if I'm examining an individual, let us say this is a person that I'm examining. This is where his heart is located. Right, this is right ventricle. This side is left ventricle. I have the arch of aorta here. Now right ventricle is contracting, left ventricle is contracting, but I can't see it, right? I can't see it. The only thing that may be visible and felt is the tip of left ventricle. Tip of the left ventricle contracting. That point of maximal impulse which can be seen is called as apex beat. Why is this important? Because when it comes to cardiovascular diseases, it helps us to understand whether there is change in the size of the ventricle. So if left ventricle develops, let us say, eccentric hypertrophy, what will happen to the tip of the left ventricle? It will get displaced, right? The more the muscle mass added outside, the tip will get displaced more, right? So can I say that if I have eccentric LVH, apex beat gets displaced? Yes. And what if I dilate the left ventricle, like in dilated cardiomyopathy? So if left ventricle dilates, apex beat gets displaced. So apex beat with respect to cardiovascular problem gets displaced when there is dilatation of the ventricle or eccentric hypertrophy of the ventricle. But should the tip be displaced if I have concentric hypertrophy, like if I am adding muscle inwards? I'm not adding anything outside. The muscle is added inside only. So will the tip be displaced? No, right? So apex beat in aortic stenosis is not expected to be displaced. So in your bedside discussion, your teachers will ask, I have a patient of aortic stenosis, but apex beat is displaced. What does that indicate? It indicates that in addition to the concentric hypertrophy that is expected in AS, patient might have developed the left ventricular dilatation. Why dilatation can happen? It can happen when AS is combined with AR. So patient may be having AS plus AR. This is the answer that they are expecting. If you say, sir, it is probably LV may be dilated, because I don't expect the apex beat to be displaced in pure isolated aortic stenosis. But if he has aortic stenosis, but indeed he also has displaced apex beat, one possibility is left ventricle may be dilated, and that makes me think of the possibility of presence of an additional aortic regurgitation as well. Okay. So apex beat is expected to be undisplaced because there is concentric hypertrophy, not eccentric hypertrophy. Okay. Now comes the main part, auscultation. Of course, it's an valvular heart disease, so we are expecting to hear a murmur. So now, can any of you tell me what kind of murmur are we expecting? And if you are a beginner, second year or third year student, can you tell me what is a murmur? What is a murmur? So normally what happens is, in cardiac cycle, the closure of the valves makes sound. The mitral valve closure, when it closes, and the tricuspid valve closure makes a sound, we call it as S1. And aortic valve closure and pulmonic valve closure makes a sound, we call it as S2. So S1 and S2 are because of the closure of the valves. If the valve is normal, when it opens, it makes no noise. Opening is noiseless if it is normal valve. Okay. Then when blood moves from one chamber to other chamber, the movement is called as a laminar flow. Now, what do I mean by laminar flow? Let us say I'm looking at a pipe and I'm seeing how the particles of a fluid move in that. So if the particles of fluid move smoothly without much collision with other particles, then it is called as laminar flow. So when there is laminar flow, it doesn't create much turbulence, so you don't have much of noise created. You can imagine a river that you see in the summer. Little bit of water is there and it is slowly flowing. When you stand on the bank of the river, you don't get any noise. It's a calm thing, right? Evening, you can, like, in front of that river, you can imagine you are praying to God. Some aarti is being played in the background. Such a serene, calm environment. Because during that time, the flow is laminar. The water particles are not colliding much with each other. That's why there is no noise. But you go to the same river bank during the monsoon season, when there is literally floods everywhere. You will hear the river roaring far away, maybe 100, 200 meters away from the river itself. You start hearing the sound of the water, right? Because during that time, the flow through the river is turbulent. You can see literally waves getting created in the river. So if I make this flow turbulent, then the fluid molecules start colliding with each other, and that is called as turbulent flow. And turbulent flow produces the sound. So normally movement of blood between chambers of the heart is laminar. So that's why the movement of blood does not make any noise. When I start moving the blood from left atrium to left ventricle, no sound produced. When I eject the blood from left ventricle to aorta, no sound produced, because this movement is laminar. But the moment I make the opening small, the movement is no longer going to be laminar. It becomes turbulent, because the particles that are supposed to exit straight, now they have to make all complex paths to exit this opening. So the movement becomes turbulent, and that turbulent flow of blood makes the noise. And this noise is what we call as murmur. So murmur is the sound produced by turbulent flow of blood. How can I make the flow turbulent? Either make the passage narrow or increase the flow. See, I just gave you an example of a river. During summer, we don't hear the the water flowing through the river because it is laminar. What changed during the monsoon? The flow increased. So either increase the flow or make the passage narrow. Like on the river, put a dam and have only a small gate. And then you stand on the other side of the dam, and then when water flows, you can clearly hear, because water came laminar, but once the dam is put, the opening is now narrow. After this, there is a turbulent flow. So that turbulent flow, you can hear that roaring sound of water coming from the dam, you can hear, right? Same thing happens in the heart. The normal flow is laminar, but if I increase the flow or make the passage narrow, I start creating the turbulent flow, and that turbulent flow is murmur. So you can understand one thing very clearly, that a murmur in a valvular heart disease is heard in that phase of cardiac cycle during which the blood flows through that valve. So now tell me, the blood flows through aortic valve during systole or diastole? blood flows through aortic valve during systole or diastole. The basic concept of cardiac cycle is that in the diastole, we fill the ventricle. The ventricle receives the blood in diastole, and in systole, it ejects. So blood is moving between mitral valve and left ventricle during diastole. I fill the blood. Now, whatever filled blood, we call it as end diastolic volume. Now, I want to eject it during systole. Absolutely right. So the blood moves from left ventricle to aorta during systole, and if the opening is narrow, while moving, it will create the turbulence, and you hear that turbulent flow as murmur. So the murmur is going to be systolic murmur. It's not going to be a diastolic murmur, right? So at least this much you can understand. If I had a mitral stenosis, blood moves during diastole, so I would have had a diastolic murmur. So MS is diastolic murmur, but AS is going to be systolic murmur. The minimum thing you're expected to mention to your teacher is that you're expecting a systolic murmur, but more detailed explanation is expected if you want more marks. Okay. So let me tell you exactly how the murmur sounds like and looks like. Okay. So let us say that this is what I'm representing as cardiac cycle. So let me say this is S1, this is S2. Again, I will have S1 and the cycle continues. So in the cardiac cycle, when we hear externally, between S1 and S2, we have ventricular systole. And between S2 and S1, we have the diastole. So I'm going to hear murmur in this region or in the second region. Of course, systolic murmur means I'm going to hear it in this region, right? Okay. Now let me take you through how exactly we do systole so that you can understand this murmur as well and you will not forget it ever again. So whatever blood I transfer from the left atrium, let us say I had some amount of blood in the left atrium, I transferred it to the ventricle during diastole, and at the end of the diastole, whatever blood I have in my ventricle, this volume we call it as end diastolic volume, right? Normally in a resting condition, it is around 120 to 125 ml. That's normal, but it can vary depending on our status. If I'm doing workout, if I'm stressed, the values change. In a resting condition, it is around 120 ml. Okay. Now this blood is the burden on the heart. More it is, more work heart needs to do. That's why we have called this also as preload. Now I want to eject this blood into the aorta. To eject this, I have to contract the left ventricle because fluid moves from high pressure to low pressure zone. And I want to increase the pressure in the ventricle more than aorta. So if I have to increase the pressure, how can I increase? Boyle's law. What it said, pressure and volume are inversely related. So if I have to increase the pressure, I have to decrease the volume. That is how the contraction of the left ventricle happens. So if I contract the left ventricle, volume decreased. And if volume decreased, pressure increased. Once the pressure increases, the blood moves from left ventricle to aorta, right? And for this contraction, I need an electrical signal, and that will come from SA node. Once the SA node's electrical signal starts traveling through the ventricle, it produces QRS complex. So your QRS complex that you see on the ECG is responsible for this ventricle's contraction, and that contraction is responsible for the movement of blood from left ventricle to aorta, right? That is what is going to happen in the systole. Okay, fair. Now exactly how the cardiac cycle inside the systole is broken is, first, I will have the aortic valve closed. I have blood in the ventricle, we call it as end diastolic volume, and the ventricle starts contracting because there is no mechanism to pull and open the aortic valve. The aortic valve has to open because of high pressure in the ventricle. So first I have to elevate the pressure in the ventricle. This pressure pushes and opens the aortic valve. During that period, when the valve was closed but ventricle was contracting, will I hear a murmur? Let us say, if can anybody answer this? So I just filled the ventricle, diastole is over, I have end diastolic volume. Now the responsibility is on me to push this to aorta. So I start contracting because SA node has given me an electrical impulse in the form of QRS, so that is helping me contract. I start contracting. At this point of time, the aortic valve is still closed. For it to open, I have to have high LV pressure, and that will open the gate. So till the valve is open, there is no movement of blood. If there is no movement of blood, is there any turbulence? No. No turbulence means no murmur. And this phase of cardiac cycle where ventricle is contracting to open the aortic valve, we will call that as isovolumetric contraction. So first phase of systole is going to be isovolumetric contraction. During isovolumetric contraction, the aortic valve is not open, so blood is not moving from left ventricle to aorta, so no murmur. Okay, fair. Now at the end of isovolumetric contraction, I have sufficient high left ventricular pressure, and that pressure makes the aortic valve open. Normally only closure makes a sound, opening does not make the sound. But this time this valve is calcified, stiff. While opening it may make a sound. I have to give a name to it. So can anybody tell me what name I should give to it? If a valve which is stenosed, while opening it makes a sound. So just imagine a door. Normally when you close the door, shut the door, it makes a noise, right? Thud you hear. If the valve or the door is not tight, opening does not make much noise. Same applies to aortic valve or all the valves as such. Normally only closure makes a noise, but if it is stenosed or stiff or tight, while opening also it makes a noise. Like your regular door, while opening, if it is tight, it makes chirr noise. Exactly, that's what is happening with the aortic valve as well. While opening, it is making a noise now because it is stiff and stenosed. It's not usual flexible valve. That sound we will call it as click. So you might have heard about this ejection click. So after the isovolumetric contraction, the opening of the aortic valve makes a noise, and I'm going to call this noise as the click. Sutapa and Kalyan, very good. So this noise that I'm going to hear here will be called as a click, or you can also call it as an ejection click, because after this the valve is open now and the blood starts moving. The blood starts moving from left ventricle to aorta now. Okay. Now again remember, the mitral stenosis, if I have mitral stenosis, there also opening of the valve may make a sound if it is stiff. That sound we will call it as snap or opening snap. Here we are going to call it as ejection click or simply click. Why that is called snap and this is called click? So remember, in systole the pressures in the chambers is quite high. So the noise that I hear when the aortic valve opens is loud. But in the diastole the pressures are low. So the noise that opening makes is low. So it is comparable to, this is what we call chutki is snap. Click is what we make from the throat. That is click. So this is more loud, right? So systolic sounds of the valves that open in systole, if they are making a noise, they make much loud noise. So we will compare it to click. But the diastolic opening valves, when they open in diastole, they make less noise. So we will call it as snap. Snap is not as loud as click. Okay. So I heard a click. After that, the blood started moving from left ventricle to aorta. Now I will start hearing the murmur. Now the murmur intensity also is not going to remain same throughout the systole. The intensity first increases and then decreases, because when we eject the blood, we have two phases of ejection. First one is called as rapid ejection and then delayed or slow ejection. So in rapid ejection, the movement of blood from left ventricle to aorta is with increasing velocity. During slow ejection, the velocity goes on decreasing. So more the velocity, more the turbulence, more the turbulence, more the intensity of the murmur. Decreasing velocity means decreasing turbulence, decreasing intensity of the murmur. So during rapid ejection, the murmur intensity goes on increasing. It goes on increasing. And then during delayed or slow ejection, the murmur velocity goes on decreasing. So it creates a murmur which is kind of diamond shaped, right? So first phase was rapid ejection where the murmur intensity was increasing, and then delayed or slow ejection where it was decreasing. So this is the murmur that we are going to hear. So if you have a patient or if you encounter a patient anytime in near future in your hospital, pay attention, listen to the murmur closely, and you will be able to identify that the murmur starts becoming a little louder and then the loudness starts dropping. So it has a peak and then the peak starts receding. Now tell me, what kind of systolic murmur is it? Should I call it as pan-systolic murmur? When I say pan, it means it is running throughout the systole. From this end of systole to that end, means from S1 all the way to S2. Then you can call it as pan. Is it running from S1 all the way to S2? No. Can I call it as early systolic? It is not heard in the early part of the systole, right? So then what should I call it as? If it was only heard in the slow ejection part, maybe I would have called it as late systolic. I can't call it either. So either I have to call, because it's somewhere in the middle of the systole it is starting, either I have to call it as mid systolic, or more technical term is we can call it as ejection systolic. Why am I calling it as ejection systolic? Because the murmur is heard throughout ejection, because ejection is where the blood is moving, right? In the ejection, the blood is moving. In isovolumetric contraction, the valve was closed, blood was not moving. First rapid ejection after isovolumetric contraction, then slow ejection. So in rapid ejection, murmur intensity increase, slow ejection decrease. So I heard the murmur throughout ejection. That's why we can also call it as ejection systolic murmur. Now in the murmur, the teachers expect you to give a description of this increasing intensity and decreasing intensity. The technical term would be crescendo, decrescendo. So what you should write is, you get a murmur. Please write this picture that gives a very clear idea to the examiner that you know about the murmur, and then mention you get this ejection systolic. If you want, you can also write it as mid systolic. Ejection systolic, crescendo, decrescendo murmur. So it is systolic but not pan, ejection, and its intensity goes on increasing and decreasing. Ejection systolic, crescendo, decrescendo murmur. In the theory exam, you don't have to write best heard in, but in a practical, they will ask where you will hear the aortic stenosis murmur best. So you know that for every valve, there is a representative area where the murmur is best heard. So can anybody tell me where is the aortic area situated on the chest? And it's not wrong, if you have time, do put a small picture or image to represent the area of auscultation for the aortic valve. Where is the aortic area situated? Yes, the aortic area is situated in the right second intercostal space. So if this is right, this is left. So on the right second intercostal space, cardiopulmonary, very good. So on the right second intercostal space, we have the aortic area. So some of you may be wondering, so why is it on the right? Why is it? The valve is of the left side of the heart, right? Aortic valve is between left ventricle and aorta, but why its area is on the right? So please remember, when I create the sound, because of the turbulence, the sound travels in the direction of jet of blood. So if this is where my heart is situated, this is my left ventricle, okay, and this is the aorta that is coming out from it, and this is where the aortic valve is. So the direction of jet of blood is towards right. So when I eject the blood from left ventricle to aorta, the direction is towards right. So the sound propagates more towards the right. So that's why right second intercostal space is the aortic area. The pulmonic area is on the left. The pulmonic valve is on the right side of the heart, but the direction of jet of blood is towards left. So that's why the pulmonic area is in the left second intercostal space. So best heard in right second intercostal space, right second intercostal space. Another thing you have to mention is whether the murmur is best heard in inspiration or expiration. That's a very, very important point that they will ask in your case presentation. So again, a simple rule, we just learned that murmur is the sound produced by turbulent flow of blood. More the flow, more the turbulence, more is the intensity of the murmur, or more is the loudness of the murmur. It's as simple as that. Now in heart's cardiac cycle, the right side of the heart receives more blood during inspiration, and left side of the heart receives more blood during expiration. Now you may ask why. Ideally, both the sides of the heart should get equal amount of blood, but then things change because of respiration. How do I do respiration? Even our respiration is related to Boyle's law. Like, whole physiology is based on physics. If you have understood physics very well, then the medicine starts becoming quite easy. How do I breathe? It's all based on the two laws that we discussed yesterday also. Fluid and air moves from high pressure to low pressure zone. In the atmosphere, there is air. I want this air to go into my lungs. Can I increase the atmospheric pressure? No. God has not given me the control, right? So all I can do is I can decrease the pressure in my lungs lower than that of the atmosphere. If I do that, then the air from the atmosphere, because now atmospheric pressure is higher than the lungs, so air from the atmosphere will come into my lungs. But how will I decrease the pressure in the lungs? I will apply the Boyle's law. I will increase the whole thorax volume. If I increase the volume of the thorax, the pressure inside the thorax decreased. So all the structures inside the thorax, pressure in them will also decrease. Means inside the lung, the pressure will decrease. And because of that, the air from the atmosphere will come into the lungs, right? Now, how will I do expiration? The pressure in the lungs has to be more than the atmospheric pressure. So whatever lungs that had expanded during inspiration will recoil. If the lungs recoil, the volume of the lungs decreased. Volume decreased means pressure increased. So once the pressure in the lungs becomes more than atmospheric pressure, the air will leave the lungs and go to the atmosphere. That is our expiration, right? As simple as that. But because I decrease the pressure in the whole thorax, not just the lungs during inspiration, the pressure in the right side of the heart will also get decreased. And because of that, the blood from inferior and superior vena cava will get into the right side of the heart more easily. Like if the whole thorax pressure is negative, more blood will flow into the right atrium through the veins. So that's why increase in the right sided blood flow happens during inspiration. Okay. Now this extra blood that came to the right side of the heart will pass the lungs and reach the left side of the heart during expiration. So left side of the heart gets more blood during expiration, and the right side of the heart gets more blood during inspiration. So that's why if I had pulmonary stenosis or tricuspid stenosis or any of the right valvular pathologies, the flow is more during inspiration. So murmurs of right side of the heart will be heard better during inspiration. But murmurs of the left side of the heart, because left side of the heart gets that extra blood during expiration, they will be heard better in expiration. So this you can write for all left-sided conditions. Means mitral stenosis, mitral regurgitation; aortic stenosis, aortic regurgitation. Murmur is best heard in expiration. Pulmonic stenosis, pulmonic regurgitation; tricuspid stenosis, tricuspid regurgitation. Murmur is best heard in inspiration. So here we should write, because it is a left-sided heart pathology, we will be writing best heard in right second intercostal space with patient's breath held in inspiration. Sorry, breath held in expiration. Breath held in expiration. Okay. Bolt, I will talk about the pulses paradoxes. Okay, breath held in expiration. Now, one last thing that bedside discussion, the teachers might expect you during the bedside discussion is what should be the position of the patient for you to be able to hear the murmur. In the theory paper, of course, they are not going to expect all this. As long as you mention that it is a ejection, systolic, crescendo, decrescendo murmur, they are going to give you the marks and move forward. But in the bedside discussion, they are very judgmental because you are right in front of them. They are asking you more. What should be the position? So while auscultating, bringing the valve closer to the stethoscope makes it more easier for us to hear the murmur. So aortic valve, that area, how can I bring it closer to the stethoscope? By asking the patient sitting and leaning forward. You can apply this to both pulmonic as well as aortic valve. Patient sitting and leaning forward brings the valve closer to the auscultating stethoscope and makes the murmur more clearly audible. But for mitral valve, mitral area is in the apex, the tip of the left ventricle that we say, that location is called as apex. Mitral area is apex. So there I have to turn the patient to left lateral decubitus, and then I will be able to hear the murmur better. Why is this important? Because in the bedside discussion, if the teacher asks you, show me how do you auscultate for aortic stenosis murmur, he is not expecting you to identify the murmur. As an undergraduate student, you're not expected to be able to recognize a murmur. If you recognize, that's a brownie point, but you're not expected to. What as an examiner I'm assessing is whether you know the methods correctly. So if I tell you to auscultate an aortic stenosis murmur and the patient is lying on the bed and you just put a stethoscope, I know that you don't know anything about auscultation, and that will be a negative mark for you. But if you ask the patient to sit, lean forward, ask him to take a breath and then exhale and then hold the breath and then you place the stethoscope. I know the methods are right. Whether you recognize the murmur or not, just let me check the speed. Okay, I think some of you might be facing the internet issue, but my speed shows good. Okay, so I'm getting a quite good speed of 300 Mbps. So at that speed, it should not be lagging from my end. Either the server issue or your device may be having an issue. Okay, fair. So I was telling you about. Okay, good. So we were discussing about this murmur, and I think Sutapa had asked why breath we should be examining in expiration for the left side of the heart. So left side of the heart gets more blood supply during expiration, right during inspiration. So that's why if it is a right heart valve pathology, pulmonary valve or tricuspid valve, you better hear it in inspiration. If it is left, you better hear it in expiration. Okay, so now that the examination findings are completed, this is what you're expected to mention. Now we will talk about diagnosis. The diagnosis of all valvular heart disease for your practical as well as theory exam is pretty simple. All you have to do is investigation of choice. Clinically, it's based on symptoms and auscultation findings, but for confirmed diagnosis, we have to go for investigation, and investigation of choice is echocardiography, two-dimensional echocardiography. You can write it as 2D echo or echocardiography. But apart from that, if you want to write, you can mention what findings you are going to get on ECG in a patient with investigation of choice is echo. ECG alone is not enough for the diagnosis of aortic stenosis. But if I have done it, what am I going to expect? Because patients may present with angina. I don't know if it is MI or aortic stenosis. So I will do an ECG. If it is MI, ECG will show. If not, what findings I will get in aortic stenosis? We just learned in pathophysiology that there is left ventricular hypertrophy, and left ventricular hypertrophy can be recognized on the ECG. So LVH may be visible on the ECG. Nothing more we can probably see on the ECG, but we can see left ventricular hypertrophy. Okay, now if you have already watched my ECG series, you know how to recognize left ventricular hypertrophy. We follow a criteria which is called as Sokolov-Lyon criteria. You don't have to write it in your prop paper, but just for a quick recap, which basically is a simple mathematical formula. We are looking at the amplitude of S wave in V1, how many small squares the S wave takes in. Like if you look at the QRS complex, right, you have an S wave and you have a R wave. So we are looking at the depth of S wave in V1 and the height of R wave in V5 or V6. S in V1 plus R in V5 or V6. If it is more than 35 small squares, it indicates that you have left ventricular hypertrophy. You have left ventricular hypertrophy. Okay. Now in echo, 2 points I want you to write. If the opening is less than 2.6 centimeter square, normal I have already told you it is 3 to 4 centimeter square, we will call it as aortic stenosis. And if the opening is less than 1 centimeter square, we will call it as severe aortic stenosis. We will call it as severe aortic stenosis. Okay. Now the diagnosis is done. How am I going to treat this patient? I have a patient with aortic stenosis. He presented with angina, syncope, dyspnea as symptoms. On examination, I got this pulsus parvus et tardus. I have this ejection systolic crescendo decrescendo murmur with a ejection click to start with. I got an echo done and it showed that the orifice is narrow, confirmed that there is aortic stenosis. Now how am I going to manage? So when it comes to the management of any valvular heart diseases, you have to discuss it under two headings. First one is there any conservative way of managing this without doing any surgery or valve replacement? Second is definitive treatment. For all valvular heart diseases, the definitive treatment is going to be valve replacement. Okay, aortic valve opening is narrow, it's not opening completely, take it out. Put a fresh valve which opens completely. It's as simple as that. But can I do something to avoid this surgery is the question. Okay, so if they ask what is the definitive treatment, the definitive treatment is simple. That is going to be aortic valve replacement. But is there any role of pharmacotherapy? Normally, like giving drugs like beta blockers or nitrates, is that useful for a patient with aortic stenosis? Well, so please remember, so Tapasamanta, the coronaries receive the blood from aorta itself, right? And in aortic stenosis, because the opening is narrow, I am ejecting the less amount of blood into the aorta. This opening is deciding how much blood I can eject. It's small, so less amount of blood comes to aorta. From the aorta, coronaries are originating. So if less amount of blood comes to aorta, less amount of blood comes to coronary arteries. Simple. So already, because of low stroke volume, less amount of blood is coming to coronaries. Second, concentric hypertrophy that we developed has increased the oxygen demand. So one side I want more oxygen, other side I can't give it, and that's why I'm getting this angina. Okay. So as such, in aortic stenosis, there is no role of pharmacotherapy. You can't manage any of these patient's symptoms with drugs or diuretics. Why? Because if I give diuretics, it will reduce the congestion that I had in the lungs. So dyspnea will improve, but diuretics will also mean that end diastolic volume will decrease, stroke volume will decrease, right? So it will worsen the symptoms related to low stroke volume, that is angina and syncope. If I give beta blockers reduce the force of contraction of the heart. So it will again decrease the stroke volume. So there is no role of pharmacotherapy per se. The only definitive management is aortic valve replacement. So the point to note is we should avoid giving beta blockers and diuretics to a patient due to decrease in stroke volume, because both of them decrease stroke volume. I already have low stroke volume, so it can worsen the problem. So there is no role per se, right? The only thing I can do for these patients is definitive treatment, which is aortic valve replacement. There are refined indications when we should consider aortic valve replacement. At the prof exam or practical exam level, it's not required. Once you start preparing for the NEET PG, we will discuss those indications, how to remember that. We will have a flowchart. For now, just mention the definitive treatment is aortic valve replacement. The question is, the most common cause for aortic stenosis is age-related degeneration. So most of your patients are in their 70s or 80s, not very fit for the open heart surgery for valve replacement. No cardiac surgeon would love to do those cases because it is risky. So if the patient, and most of the times in your 70s or 80s, you have multiple other diseases. You're diabetic, you're hypertensive, you also have coronary artery disease, you have dyslipidemia, you have multiple other problems. You may not become very fit for an open heart surgery. So for those patients, what is the alternative I can offer? For patients deemed unfit for surgery of the murmur, I should mention the area and the best heard position, inspiration or expiration. Then management for all valvular heart disease, you are going to mention definitive treatment as aortic, as the valve replacement, mitral stenosis, mitral regurgitation, pulmonary stenosis, pulmonary regurgitation. Definitive is always valve replacement. For some valvular heart diseases, there may be a role of conservative management of pharmacotherapy. For some, it is not. For aortic stenosis, there is no. Other valves I will tell you. So if you remember that, you can follow the same template and you can answer all the valvular heart disease questions. Even if it comes instead of aortic stenosis, it comes to pulmonary stenosis, you can write the same template there. Okay. So let us take the example of mitral stenosis as well. So the snap refers to the sound produced by the valves that open in diastole. As I've already told you, normally when valves open, they don't make any noise. Only stenosed valve, when there is stenosis while opening, they make a noise. That noise, either I will call it as click or snap. The valves that open in systole, if they make a noise, we will call it as click because it is much louder. And the valves that open in diastole, if they make a noise while opening, we call it as snap. So mitral valve and tricuspid valve open during diastole because blood moves from atria to ventricle during diastole. So when they are opening, if they make a noise, it is snap. Mitral stenosis, we will have snap. Tricuspid stenosis, we will have snap. But aortic valve and pulmonic valve open in systole because blood moves from ventricles to the arteries during systole. So while opening, if these valves make noise, that is AS or PS, we will call that noise as click. Okay. So Atul, eventually, because as the stroke volume decreases, the more and more blood is left behind in the ventricle. So eventually you will have increase in the preload, not to start with. To start with, you have increase afterload because of the narrow aortic valve opening. Because see, diuretics will make you excrete more urine. So the circulating blood volume decreases. So the amount of blood reaching the heart also comes down. Instead of 5 liter, my circulating blood volume became 4 liter because 1 liter I excreted in urine. So now if circulating blood volume is 4 liter, the amount of blood reaching the heart is less. So if the amount of blood reaching the heart is less, the heart will eject less. Already it is ejecting less because of narrow opening. Now it will eject further less because the amount of blood reaching the heart is less. So stroke volume further decreases if I give diuretics. A normal person can tolerate the diuretics, but not a patient of aortic stenosis because their stroke volume is already low. Further low stroke volume means it will complicate the syncope and angina symptoms. That's why we avoid beta blockers. Same story. Beta blockers reduce the force of contraction of the heart. So less the force of contraction, less is the stroke volume, and thus you will have again decrease in the stroke volume. Okay. Now we will talk about the mitral stenosis as well. So if I have to talk about mitral stenosis, we will begin with the mitral valve. Few points about mitral valve. And as you know, the mitral valve is the valve that is guarding the left ventricle and left atria. It is between left ventricle and left atria. So if this is my left atrium, this is left ventricle, this valve is the mitral valve. Its job is to allow the movement of blood from left atrium to left ventricle when during diastole, because I fill the ventricle during diastole, I eject from the ventricle during systole. So mitral valve opens in diastole so that blood moves from LA to LV. It remains closed in systole so that the blood does not move back. Okay. So mitral valve, just like the aortic valve, this will also have a connective tissue ring. And that connective tissue ring, we always call it as annulus. It is called as annulus. But my aortic valve had 3 cusps. But mitral valve has only 2 cusps. 2 cusps. Aortic valve was tricuspid. The mitral valve has only 2 cusps. You can call one of them as anterior mitral leaflet, the other one as posterior mitral leaflet. Only 2 leaflets or 2 cusps. But then mitral valve has an additional structure. What is that? Mitral valve has papillary muscles and chordae tendineae. Our aortic valve does not have them. But mitral valve has papillary muscles and chordae tendineae. So these structures, we will call them as papillary muscles. And these structures, these tendinous structures, we will call them as chordae tendineae, or in simple words, chordae. Aortic valve did not have it, but mitral has it. Why mitral requires it? Why not aortic? So you have to remember that in the cardiac cycle, the highest pressure phase is systole. Systole is where ventricle is contracting. Ventricle is strong and muscular. So it generates a lot of force. The intraventricular pressure in systole goes as high as 140 millimeters of mercury. Right? Okay. So during that time, the mitral valve is supposed to be closed and aortic valve is supposed to be open. So aortic valve need not stay closed in systole, it has to open. But mitral valve has to stay closed in the systole. It is supposed to open in diastole. And to make sure that it remains closed and does not open in the opposite direction because of high intraventricular pressure, we need this papillary muscles and chordae tendineae. So you can imagine this papillary muscle and chordae tendineae as the ropes tied to boats on the sea beaches or the river banks. Why ropes are tied? Not to pull, mainly to prevent so that the boats don't flow away. right? So similarly, I don't want these mitral valve leaflets to open in the opposite direction during systole. So to hold them in position, nature has given us papillary muscles and chordae tendon. So it has a connective tissue ring, two cusps, two sets of papillary muscles and chordae tendon. This is the structure of our mitral valve. Now this mitral valve, its normal open orifice, when it opens, the open orifice is 4 to 6 centimeters square. The aortic valve was 3 to 4 centimeters square. This is 4 to 6 centimeters square. And when it is less than 4 centimeters square, we will call it as mitral stenosis. And when it is less than 1 centimeter square, traditionally it is called as severe mitral stenosis. But I also want you to be aware, you need not write it, but I want you to be aware that in Harrison, he mentions less than 1.5 centimeter square as severe mitral stenosis in the current edition. So there are logics and reasons behind that. At a UG level, you don't have to really bother, because generally mitral valve replacement or a procedure is considered when the orifice is less than 1.5 centimeters square. So that's why he labels it as severe. The traditional older textbooks mention 1 centimeter square as severe. So what your professor is going to think of as severe, I don't know. So you can go by the traditional answer, say sir, less than 1 centimeter square is considered as severe. He says no. Do you know about the latest update? Then you can say sir, yes, current edition of Harrison says less than 1.5 centimeter square is considered as severe. So that you can handle the situation diplomatically without offending your teachers in the bedside. Okay, so this is about the mitral valve. Right now, let us talk about the mitral stenosis. The notes will be available on the Telegram as soon as the class is over. So we'll begin with the causes. So when it comes to causes, I want you to remember only one cause. I know there are n number of causes possible, but they're extremely rare. So in your theory exam, I just want you to mention the most common cause, that is going to be rheumatic heart disease. RHD is the most common cause for mitral stenosis. And in every probability, your practical case discussion will be centered around mitral stenosis only. If not, then aortic stenosis, if it is about valvular heart disease, because these are the two cases which your teachers can grab. They may be able to find some cases. The other, like pulmonary stenosis, pulmonary regurgitation, tricuspid stenosis, they're exceedingly rare. They're very difficult to find. So most likely you will not get those cases in your practical. If you're getting a valvular heart disease, it is either going to be mitral stenosis, because in India, rheumatic heart disease is still very common, though it is less from my days till now, but it's still very common. Or the second, aging. The population is aging and you may be able to find some aortic stenosis patients. Okay. The other causes, if you want to remember or mention, I want you to mention one left atrial myxoma. What is this left atrial myxoma? There may be a tumor in the left atrium which may come and block this the mitral valve opening and create a stenosis like picture. We will call it as a left atrial myxoma. So these are the two things, RHD and left atrial myxoma. Now, what symptoms it will lead to understand that, we have to understand the pathophysiology. So if I develop mitral stenosis, what all problems I'm going to face? Now let us say this is my left atrium. Its opening has become very narrow. And once its opening becomes narrow, will I be able to transfer the normal amount of blood that I transfer from left atrium to left ventricle? Opening becomes a deciding factor, right? If I have small opening, I can transfer only less amount of blood. If the opening was fully normal, completely open, I could transfer more amount of blood. Because of the narrow opening, the filling of the left ventricle during diastole decreases. So if the filling of the left ventricle during diastole decreases, I have less blood in the left ventricle at the end of the diastole. And what is that volume called as? End diastolic volume. So mitral stenosis leads to decrease in the end diastolic volume, because I could fill only less quantity of blood. And if the end diastolic volume is less, I already have less blood in the ventricle. and when I eject this blood into the aorta, I had less, I will eject less. So what will happen to the stroke volume? By default, whenever end diastolic volume decreases, we will have decrease in the stroke volume. Okay, can anybody tell me what is the relationship between end diastolic volume and stroke volume? Normally, not talking about mitral stenosis, but normally, what is the relationship? So Tapa, very good. So do you think all the amount that is there in the ventricle at the end of diastole gets ejected as stroke volume? No. So normally in the ventricle at the end of diastole, we will have around 120 to 125 ml of blood. That is my end diastolic volume. But what is the usual resting stroke volume? We expect around 70 ml. Means some percentage of end diastolic volume gets ejected as stroke volume, and the remaining blood stays in the ventricle. It becomes part of the next diastole, and that blood that stays in the ventricle, we call it as end systolic volume. That is around 50 ml. That means I had 120 ml at the end of diastole, 70 I pushed out, 50 stayed. Systole is over. Now in the next diastole, again I receive 70 ml. It makes it 120. Out of that 120, again I eject 70, 50 stays back. So ventricle always have some amount of blood. It never becomes completely empty. Okay. So this is end systolic volume, this is stroke volume, this is end diastolic volume. Now if I express it in terms of percentage, how much percentage of end diastolic volume got ejected as stroke volume? We call that as ejection fraction. So ejection fraction is nothing but the percentage of end diastolic volume ejected as stroke volume. If I eject 50% of end diastolic volume as stroke volume, then ejection fraction is 50%. So in that case, like 120 ml was my end diastolic volume. I ejected 60 ml as stroke volume. How much percentage I ejected? Half, 50%. Then my ejection fraction is 50%, right? So this is the concept of ejection fraction. Percentage of end diastolic volume ejected as stroke volume is called as ejection fraction. Normally it is 60 to 70%. Now in mitral stenosis, what happened? My end diastolic volume itself is decreased. Instead of 120 ml, let us say it has become 80 ml. Because my mitral valve opening was narrow, it did not allow me to transfer good amount of blood. So I have only 80 ml as my end diastolic volume. So out of that, my normal ejection fraction is 60%. So I will eject 60% of it as stroke volume. 60% of 80 will be 6 into 8. So that will be 48. So 48 ml becomes my stroke volume. If I had same ejection fraction of 60%, but normal end diastolic volume, I would have got a stroke volume of 70. So now what happened? Because of decreased end diastolic volume, my stroke volume also decreased. So in aortic stenosis, the stroke volume was decreased because of the increased afterflow or the narrowing of the aortic valve opening. Here, aortic valve opening is fine, no increase in the resistance, but because I had less to start with. It's like in aortic stenosis, you have the money, but your dad is not allowing you to spend. In mitral stenosis, your dad is not stopping you from spending, but you're not able to spend because you don't have the money. You have less money, right? So I ended up with decreased stroke volume. And what symptoms I will get if I have decreased stroke volume? The decreased stroke volume will result in fatigue and syncope, right? The same symptom that we have already written. Fatigue and syncope. So syncope will come even in mitral stenosis patients. Okay. The next problem is what is going to happen to the left atrium. The opening is narrow. So to push the blood through this narrow opening, left atrium starts struggling, right? It has to do more work. So if it does more work, its muscle mass starts increasing. So it develops left atrial hypertrophy. So therefore I will repeat about ejection fraction one more time after I complete the discussion. Okay. So you will develop left atrial hypertrophy. Okay. What will happen to the pressure inside the left atrium? See, I have a bottle, I'm squeezing it, but the opening of the bottle is small. So inside of the bottle, pressure will increase, right? So let us say I have this bottle, I'm squeezing it, but opening is narrow. So pressure inside will increase. Now the nature does not want the pressure in this bottle to increase. So then what nature should do? If the opening is narrow, there is increase in left atrial pressure. But the nature doesn't want you to increase the pressure. So what should the nature do? So mitral stenosis leads to increase in left atrial pressure. Only one solution is there, Boyle's law. What Boyle's law says, if you want to bring down the pressure, you have to increase the volume. So to compensate for this increasing pressure, to make sure that it does not affect the heart, the left atrium dilates. So increasing left atrial pressure results in one left atrial dilatation. This is also called as compensatory dilatation because it is trying to compensate for the increasing pressure. Why should it compensate? The answer is simple. If left atrial pressure increases, then we know that pulmonary vein pressure has to increase. Then only blood will come from pulmonary vein to left atrium. So the left atrium does not want to burden the pulmonary veins. Pulmonary veins pressure should not increase. So then it dilates. As long as it can dilate, it keeps dilating so that the left atrial pressure remains low, so that the blood easily flows from pulmonary veins to left atrium. But there is a limit to dilatation. Left atrium is not going to become miles long. So once its limit of dilatation is reached, then pressure will start rising again. Once pressure starts rising, then the pulmonary vein pressure will have to rise. Pulmonary vein also does not want to burden the pulmonary capillaries. So what it should do? It will also dilate. As long as it can dilate, it will keep dilating so that the pressure is maintained. But once its limit is reached, it failed, then the pulmonary capillary pressure starts rising. The pulmonary capillaries also don't want to bother the pulmonary artery behind, so they will also dilate. When they dilate, they hold more blood, that is pulmonary congestion, we will have dyspnea. So whenever I start in the left heart, I end up in the lungs and I will have dyspnea. So dyspnea is going to be a standard symptom that you can write for all left heart diseases. But once the limit of pulmonary capillary dilatation is reached, it can't dilate anymore. Pressure will start rising. Now the pulmonary artery pressure has to go above the pulmonary capillary. And once the pulmonary artery pressure increases, we call it as pulmonary hypertension. If you remember from the yesterday lecture, the most common cause for pulmonary hypertension is left heart disease. And this is one classical example. So problem that started here will eventually end in the pulmonary artery. Eventually right heart will also fail. Right. So we can write this down. So compensatory left atrial dilatation, eventually that will lead to pulmonary congestion because the pressure keeps rising till it reaches the pulmonary capillaries. And from the pulmonary congestion, I will expect development of dyspnea. And pulmonary congestion will also lead to increase in the pulmonary artery pressure one day, and that will result in pulmonary hypertension. Pulmonary hypertension. Okay. Now, dyspnea is one symptom. What pulmonary hypertension will lead to? Pulmonary hypertension we have studied as a question yesterday. Mean pulmonary artery pressure more than or equal to 20 millimeters of mercury. The most common cause is left heart disease. Second most common cause is lung disease. That's what we call as car pulmonale. COPD and ILDs can cause. If left heart and lungs are not affected, you still have pulmonary hypertension, then it is called as pulmonary arterial hypertension or PAH. Okay. So what examination findings this pulmonary hypertension can lead to? It can lead to loud P2 and right parasternal, because pulmonary hypertension will lead to right ventricular hypertrophy, and that will lead to right parasternal heave or lift. Now why am I talking about this here? Because in the bedside discussion, if it is a mitral stenosis case, your teachers will ask, how will you get to know whether a mitral stenosis patient has developed pulmonary hypertension or no? You can say, sir, I will have loud palpable P2. This answer pleases your examiners, and generally they will move forward, right? So I want you to remember this point because they do ask. Okay, you say this is a case of MS. I want to know whether he has developed pulmonary hypertension or not. What is the gold standard investigation? Right heart catheterization. But your teacher says, I don't want to do right heart catheterization. Patient can't afford. Patient is not giving consent. Can you clinically identify whether he has got pulmonary hypertension or not? And you can say, sir, if loud P2 is there, I can be sure that he has got pulmonary hypertension. Okay, this is the answer that they are expecting. Now, one more thing that this left atrial dilatation leads to. It's large left atrium, right? it may compress the left recurrent laryngeal nerve. So if you think back about anatomy, the left recurrent laryngeal nerve comes down, arches around the arch of aorta, and then goes up to the larynx. And because it has a close relationship with the aorta and the heart, this enlarged left atrium may compress it. And when it compresses it, its function is disturbed, and its function is vocal cord movement. So you end up with hoarseness of voice. And what is this manifestation called as? This will result in compression of left recurrent laryngeal nerve, right? This will result in, I will address that. And this manifestation is called as Ortner's syndrome. Okay, so imagine pulmonary hypertension means your pulmonary artery pressure is high, right? So imagine that you're closing a door. You're closing a door of a room in which pressure is already high. Like you might have imagined in seen in movies and all, some blast happens and all that blast particles are coming, and in this one particular place the hero and heroine are there and they want to shut that door. So pulmonary hypertension means pulmonary artery pressure is high, and this pulmonary valve is nothing but that door of that room. So when I shut a door against a high pressure chamber, it makes a louder noise. So indirectly, whenever you have pulmonary hypertension, your P2 becomes loud. In systemic hypertension, you can have the aortic valve closure also little louder. The A2 can become loud. Okay. So we call this hoarseness of voice as Ortner's syndrome. Okay. So your examiners are expecting you to talk about dyspnea, talk about syncope, and they may ask, what do you suspect if a patient of mitral stenosis develops hoarse voice? You can say, sir, probably left atrial enlargement has compressed the left recurrent laryngeal nerve, right? Sometimes they try to confuse you saying left recurrent laryngeal nerve or right. Be assured it is left. Right has no proximity to the heart. Okay. So from the pathophysiology, we have an idea what symptoms to expect, right? Now, let us talk about its diagnosis and management. So Tapasamanta, yes, you can hear that loud P2 through auscultation. Again, all these loud noises that we're talking about, soft S1, loud S1 and all. So please remember, they are appreciable only when you have heard hundreds of normal P2 and normal A2, normal S1. So make sure that every time you have a stethoscope and a patient in front of you, auscultate. Whether you find something or not, keep auscultating. That trains your ears and brain to pick up the normal. And next time when you hit a loud S1, loud S2 or loud P2, loud A2, soft S1, you will be able to recognize that it is not sounding normal, it is little different. Okay. We did not write about the clinical features, right? So let me first write about the clinical features and then we will talk about the diagnosis. As I've already told you, for all valvular heart diseases, you should focus on the BP, pulse, apex beat, and auscultation. Here stroke volume is less, so the pulse amplitude will be low. So you will have a low amplitude pulse, which you can also call it as pulsus parvus, or common terminology, the feeble pulse. The BP is expected to be low because of the low stroke volume, but it gets countered by RAS, so you're expecting it to be normal. Now, can anybody tell me what will happen to the apex beat? Will it be displaced or will it be found in the normal position? Med student, a very good question. Aortic stenosis can also cause pulmonary hypertension, right? Yesterday when we discussed about pulmonary hypertension, we said left heart disease, and we have mentioned it categorically that when we say left heart disease, it includes aortic stenosis as well. The reason I am talking more particularly about it in mitral stenosis is the chances of mitral stenosis causing pulmonary hypertension is much high than the chances of aortic stenosis causing pulmonary hypertension? The reason is pretty simple. See, further away the pulmonary artery is from a pathology, the involvement will become late. Like if I develop aortic stenosis, first pressure in the left ventricle will increase, then pressure in left atria will increase, then pulmonary vein, then pulmonary capillary, then it will reach pulmonary artery. But if mitral stenosis, this chamber is eliminated from the circuit. So immediately left atrial pressure increases, then pulmonary vein, then pulmonary capillary. I will reach the pulmonary artery much earlier. So that's why chances of mitral stenosis causing pulmonary hypertension is much higher than aortic stenosis. It does not mean aortic stenosis will not cause. It can cause any left heart disease, aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation. All of them can cause pulmonary hypertension. This usually comes in the discussion of mitral cases because that is where we very often see it. Okay. The atrial hypertrophy does not cause the displacement of apex because apex is nothing but the tip of left ventricle. So if atria enlarges, the left ventricle won't get displaced. Left ventricle will stay there only. Only when left ventricle enlarges because of dilation or eccentric hypertrophy, we will have displacement in the apex beat. And because here we don't have that happening, left ventricle's work is not increased. In fact, by filling less into the left ventricle's work is reduced. So that's why we are not expecting it to be displaced. Apex beat is undisplaced because there is no eccentric LVH or dilatation. Okay. Now talking about its auscultation, I'm going to get a murmur, and by now I hope you have a clarity that we are expecting a diastolic murmur, because the blood moves from left atrium to left ventricle during diastole. Through this mitral valve, the movement of blood happens during diastole, and if this opening is narrow, I will create a turbulence and I will hear a murmur. So I'm going to get a diastolic murmur. Zubi, that's a very good question. We will discuss about it in the complications. The rhythm need not always be affected. I will talk about it in the complications. So then whatever murmur I'm going to hear between S2 and S1, because S1 and S2 is systole, and a mitral stenosis murmur is going to be diastolic murmur. So I'm going to expect a murmur in the diastole. Okay. Now to understand, Dr. Is Ahmed, very good. So to understand this murmur, I want you to have a fair idea about the cardiac cycle with respect to diastole. So what do we do in diastole? In diastole, I transfer the blood from atria to ventricle, and the physics applies here also. Blood moves from high pressure to low pressure. So if the blood has to come from left atrium to left ventricle, then either left ventricular pressure should be lower than left atrial, or left atrial should be higher than left ventricle. Okay. So then how do I change this pressure? Because when left ventricle was in systole, it was contracting. So at the end of systole, left ventricular pressure was very high. Left atrium cannot increase its pressure above that of ventricle, because ventricle is strong muscular, atria is a thin sheet of muscle. Atria can never contract to build a pressure higher than the ventricular systolic pressure. So the responsibility is on the ventricle. Ventricle has to lower its pressure so that it can receive the blood from atria. So in systole it contracted, ejected, that ejected blood is stroke volume. Now I'm going to start the diastole. So before I start receiving the blood from left atrium, I have to lower my pressure by relaxing. That is going to be the first part of diastole. The ventricle that was contracted in systole relaxes itself to lower its pressure. This phase we call it as isovolumetric relaxation. Isovolumetric relaxation. Once it lowers the pressure, the mitral valve opens, and then the blood starts moving from left atrium to left ventricle. So first phase of diastole is isovolumetric relaxation. The role of isovolumetric relaxation is to lower the ventricular pressure lower than that of atrium. Okay, done. I have relaxed it. The pressure is lower. The mitral valve opened, and the blood started moving from atria to ventricle. So as the diastole continues, blood is moving from atria to ventricle. So what is happening to the ventricle? Ventricle is getting filled. Atria is getting emptied. So if ventricle is getting filled, what will happen to the ventricular pressure? If I add blood into the ventricle, its pressure starts increasing. And what is going to happen to the atrial pressure? Blood is leaving the atria, so atrial pressure starts decreasing. So I will reach a point where the pressure in atria and ventricle are equalized. Can further transfer of blood happen from atria to ventricle once the two chambers are at equal pressure? Physics does not allow it. Physics says only high pressure to low pressure movement, no movement between equipressure zones, right? So this phase where blood moved from atria to ventricle because of the pressure difference, we call it as passive filling, because atria did not push the blood, ventricle lowered its pressure, and because of that it received the blood. That is passive filling. But after equalization of pressure, I may still have some amount of blood in the ventricle, and this blood has to be pushed down to the some amount of blood in the atria. This has to be pushed into the ventricle. Now the responsibility is on the atria. Atria has to contract so that its volume decreases and pressure increases, and that increased pressure will help me transfer that remaining blood from the ventricle, because at the end of passive filling both the chambers are at equal pressure. Atrial contraction should raise its pressure so that the blood moves. This phase we call it as active filling, because here atria is contracting actively. So diastole will have two phases of filling. Systole had two phases of ejection, rapid ejection and then slow ejection. Diastole has first isovolumetric relaxation for the ventricular pressure to be lowered, then mitral valve opening, and after that passive filling just because of pressure difference. And once the pressure is equal, remaining blood is pushed by active contraction, that is active filling. So in the diastole, the first phase will be isovolumetric relaxation. So do you think I will have a murmur in this isovolumetric relaxation phase? No. In isovolumetric relaxation phase, ventricle is still lowering its pressure. The mitral valve is not open yet. So in the systole, aortic valve opened after isovolumetric contraction. In the diastole, mitral valve will open after isovolumetric relaxation. So you learn one important point here. The valves open once then iso phase gets over. Aortic valve opened after isovolumetric contraction. Mitral valve opened after isovolumetric relaxation. So this is where the opening of the mitral valve happens. A normal valve makes no noise when it opens, but this is stenosed valve. It is stiff. While opening, it may make that noise. This noise, we will call it as opening snap, or in simple words, snap. Opening snap, or in simple words, snap. This noise is not as loud as the sound of opening of aortic valve. So that was loud, that's why we had called it as click. This is less loud, so we will call it as snap. After that, the valve is open. The pressure in the ventricle is now lower than that of atria because it has relaxed here. So blood starts moving. This phase we will call it as passive filling phase. And after the passive filling phase, the pressure becomes equalized between the two chambers, and then atria contracts to do active filling. So blood is moving only during this filling phase where I am filling the blood from atria to ventricle. So I will hear murmur only in the filling phase. Okay. So the murmur starts audible in the passive filling phase. But then tell me what will happen to its intensity in the active filling phase. Imagine that this is the left atria. Okay. Now I have lowered the pressure in the receiving chamber and opened this valve. Isovolumetric relaxation is done, valve is open. So initially filling happens because of the pressure difference. It is moving because of the pressure difference. So as the blood moves from this atria to ventricle, the pressure in the atria starts decreasing, ventricle starts increasing. Once they're at equal pressure, it stops. No more further movement. Passive filling is over. Now atria actively contracts to push the remaining blood. So now think about the turbulence at the level of this opening valve. In passive filling, there was no forceful push from behind, right? So I had some degree of turbulence. But in active filling, I'm forcefully pushing. So what will happen to the turbulence here? It will increase. So that increased turbulence in the active filling. So what should I call that as? Now, I have got this beautiful murmur, which is heard in diastole, but not in the first isovolumetric relaxation phase. So I can't call it as pan diastolic, right? And I can't call it as late diastolic because it's not only restricted to active. It is running throughout the filling phase. So either you can call it as a filling murmur, but no such word has been used by any other cardiologist so far. For ejection, we have used ejection systolic, right? Nobody has called it as a filling diastolic murmur. The only other term that can fit the description is mid diastolic murmur, because somewhere in the middle it is starting. It's not there throughout the diastole. It's not there in only early part. It's not there in only late part. Somewhere in the middle of the diastole it is starting. So I will call it as mid diastolic. Okay, fair. Now in the explanation, I also have to account for this increase in the intensity in active filling. Why the intensity increase in active filling? Because in active filling, atria is contracting, trying to push the blood through a very small opening. So when I try to squeeze out any fluid through a small opening actively, the turbulence will be more. When I just let it flow, there is some amount of turbulence. That is passive filling. In passive filling, just the pressure difference is making the blood to flow from atria to ventricle. But in active filling, atria is contracting and pushing. So when I squeeze the blood through a narrow opening, turbulence is going to increase. So murmur intensity increases. So we'll call this murmur as mid diastolic murmur. With this turbulence increase in active filling, we will call it as pre-systolic accentuation. Why am I calling it as pre-systolic accentuation? Because it is the last part of diastole. After this, I have systole. So just before systole started, the intensity of the murmur increased. So we'll call it as pre-systolic accentuation. So on auscultation, we are getting an opening snap and we are getting a mid diastolic. I'm just leaving a little space to fill a word. I'll come back to that. Mid diastolic murmur with pre-systolic accentuation. Pre-systolic accentuation. The increase in the intensity in the active filling phase or just before the systole starts is called as pre-systolic accentuation. Best heard in mitral area. Where is mitral area located? Can anybody tell me where is mitral area located? And because it is a left-sided heart pathology, it is best heard in breath held in expiration. And what should be the position of the patient? We generally don't use the term crescendo here. It's not wrong to use it, but traditionally what has been called is pre-systolic accentuation. Accentuation also means increase. So mitral area is at the apex, and the usual location of the apex is fifth intercostal space medial to mid-clavicular line. So if this is the mid-clavicular line, in the fifth intercostal space, medial to mid-clavicular line is where we have the mitral area. Okay, so that is our location. Now this area, this is here, right? Mid-clavicular line. So it's slightly off center. So this area can be brought more closer to stethoscope if you turn the patient leftward. While he is lying on the bed, if you turn in left side and then auscultate, you will bring the area more closer to stethoscope. So murmur can be better heard. So best heard in left lateral decubitus. It is called as left lateral decubitus. Okay. And the word that I wanted to fill here is rumbling murmur. So there is a pro tip here. If you are in a final practical exam and your PG or a SR tells that there is a case of mitral stenosis, right? Comment about the murmur only if you clearly heard it, because the diastolic murmurs are usually not very loud. This murmur that we are talking about here is very soft. That soft sound is called as rumbling. It's like whispering. So it needs trained ears to pick this murmur. So if you just say that, sir, I heard it, when your sir himself is struggling to pick that murmur, he clearly knows that you are bluffing, right? So if you hear it, then only mention. If you don't hear, no need to mention. The auscultation, I could not appreciate any abnormal sounds or murmurs. Or if you could only hear opening snap, you can say, sir, in the diastole, I heard an additional sound. I think it is opening snap, but I could not appreciate the murmur. To be able to appreciate this very slow, soft, rumbling kind of murmur, you need a very quiet room, and your examination hall is generally not that quiet room. So your teachers can easily guess whether you are making up the findings and telling it, or whether you really identified it. So don't make a fool of yourself by trying to fit all the findings to a diagnosis that your PG has told this case belongs to. Present honest findings. Okay, you appreciated, good. If not, it's fair enough. No teacher is going to fail you for missing out a murmur, but definitely they may fail you for bluffing about a murmur, right? But you should know how to examine. So most of the times, final prof practical exam is all about methods. It's not about picking up the finding. So as long as you're doing the right methods, we know that it's a learning curve. It's all our hand skills, ear skills, auscultation skills. They keep getting better with time. So if your foundation is right, your methods are right, you will become pro in near future. So as a teacher, we know that. So we are only seeing whether you're studying and applying the methods, right? So just remember, if they ask you auscultate for the murmur of mitral stenosis, then make sure you ask the patient to turn left lateral decubitus, identify the apex beat, mid-clavicular line, and then keep the stethoscope there. Once you do that, your teachers know that, okay, you know the basics, right? Okay, so this is about the examination findings. For the diagnosis, of course, the investigation of choice is always going to be echocardiography. And as I've already told you, in the echo, if you want to write about it, you can also mention that less than 1 centimeter square is considered as severe MS. Bracket, you can also mention current edition or latest update. Less than 1.5 centimeter square is also considered as severe according to some sources. So Samantha, the word pre-systolic refers to that phase of cardiac cycle that happens just before the systole starts. Systole starts after S1. So just before S1, that is called as pre-systole. That's basically active filling phase. So during active filling phase, the murmur intensity increases. So murmur intensity is directly proportionate to the turbulence of the flow of blood. So turbulence in active filling increases because see, imagine this is left atrium. I'm passing the blood from the left atrium to left ventricle through this opening. So in the passive filling phase, this valve is open and I'm just transferring the blood just because of the pressure difference. There is no active push from behind. So I don't get much turbulence here. So in the passive filling, turbulence is there, but it's not too much. But in active filling, I start squeezing this, right? So this thing that you're seeing here, I start squeezing it. So when I start squeezing it, I will create more turbulence, right? Just take any PET bottle, take a 200 ml bottle, right? And start pouring some water. You will see some degree of turbulence coming from that water coming out of that opening. But then start squeezing the bottle, you will create a lot more turbulence, right? So same thing here, turbulence increases because of active filling. In active filling, atria contracts. And that increased turbulence, we will hear it as much louder murmur. That's what we call as pre-systolic accentuation. Accentuation means increase. Okay, so echo is the investigation of choice for diagnosis. And once you're diagnosed, when it comes to management, remember what is the most common cause for mitral stenosis? The most common cause for mitral stenosis was rheumatic heart disease. And in rheumatic heart disease, the stenosis is not because of the calcification of the valves. You know, when we studied aortic stenosis, I told the aortic valve gets calcified because of the age-related atherosclerosis. That's the most common cause. But mitral stenosis, RHD is most common cause. In RHD, the two valve leaflets gets fused because of fibrosis. It is because of this fusion. It's not because of calcification. So I don't have to jump to replace this valve. I have a more simple solution. What I can do, I can pass a balloon through this valve and then dilate it. Dilatation is possible. In aortic stenosis, it's not possible because the valve is calcified. How will you dilate it? Even if you dilate it, it is calcified. It will narrow down quickly. But in RHD, calcification is not the main pathophysiologic process. It is the fusion of the two cusps because of adhesions or fibrosis. So I can make those adhesions break by passing a balloon through this and opening it. So that's why the definitive treatment is not the valve replacement. It is the dilatation with the help of balloon. Only when balloon dilatation is not possible, we go for the valve replacement. So definitive treatment is called as balloon mitral valvotomy. There is a possibility of restenosis even after balloon. So in such cases, again, we have to go for valve replacement. But the restenosis mostly happens if patient has further attacks of rheumatic fever, and that is preventable if we give the rheumatic fever prophylaxis, that is penicillin G or erythromycin or other antibiotics. So to some extent it is preventable. So most patients we may be able to manage with 1 or 2 sessions of balloon dilatation itself. But for them, for those patients where the restenosis is a big problem, we can go for the valve replacement. So definitive treatment is balloon mitral valvotomy. It's usually abbreviated as BMV. See, in mitral stenosis, the two leaflets have developed some adhesions or connections. So if I pass a balloon across this and dilate it, I can break those adhesions. It's like, two shirts, they are glued together. But if I somehow break that glue, fine, my shirt, now I can open it, right? It's like a button which is now bringing the two sides of the shirts together. If I remove the button, the problem is solved, right? So same way, the fibrotic bands or adhesions connect the two cusps together, and that's why the opening is between them is small. They're not able to separate. But if you pass a balloon and dilate, you will be able to separate them. And because that's a more not conservative but less invasive procedure than opening and replacing the valve, we will go ahead with the balloon valve valvotomy, or breaking down these adhesions. And mitral valve replacement is considered in patients with contraindications for balloon mitral valvotomy. Otherwise, most patients we try to manage with balloon mitral valvotomy itself. Okay. Now in mitral stenosis, especially bedside discussion, they do ask you about certain complications. So what are the complications? We have already discussed one complication, that is compression of the left recurrent laryngeal nerve leading to Ortner's syndrome. So that is one complication. Then second complication, this enlarged left atrium increases the risk of developing atrial fibrillation. So there is increased risk of atrial fibrillation. And again, remember this, the risk of atrial fibrillation is directly proportionate to the size of left atrium. Bigger the left atrium, higher the chance of developing atrial fibrillation. So in mitral stenosis, left atrium is dilating to compensate for the pressure rise that is happening there, right? The dilated left atrium is responsible for compressing the recurrent laryngeal nerve, giving rise to Ortner syndrome. The same dilated left atrium is also a risk factor for atrial fibrillation. So in your bedside discussions, your teachers do ask you, how do you recognize whether a mitral stenosis patient has developed atrial fibrillation? So in atrial fibrillation, you will have a pulse which becomes variable or irregular. So you will have a irregular pulse. And second, you will have varying loudness of S1, For mitral stenosis also, there is no role of pharmacotherapy per se, because there is low stroke volume. So if you try to give any drugs to reduce the congestion of the lungs that is causing dyspnea, like diuretics, it will worsen the low stroke volume related symptoms. So it is like you have to pass a balloon, dilate it, problem is solved. So please tell the teacher, if he asks how do you recognize that a patient of MS has developed AFib or not clinically without doing the ECG, you can say, sir, the pulse becomes irregular. That's a classic finding of atrial fibrillation. And the loudness of S1 starts varying. It's not same in each cycle. Sometimes S1 is loud, sometimes it is soft, sometimes it is normal. So these are the clues towards atrial fibrillation. Then one more thing, this is very important. Your teachers very often expect you to answer this. That is loss of pre-systolic
accentuation of murmur. So now tell me, why did we get this presystolic accentuation of murmur? The murmur increased because of the atrial contraction or active filling. In atrial fibrillation, atria does not contract. It only fibrillates or shakes. So if it is not contracting, it is not squeezing the blood. If it is not squeezing the blood, it is not increasing the turbulence. So you will not get that accentuation, right? So that is also one more important. So if you're able to answer these three, your teachers will be more than pleased to give you full marks, close to full marks on your bedside. And if you've written this in your theory paper, your answer is complete, right? Mitral stenosis, it was only syncope and dyspnea, no angina, right? So similarly for AR, MR, PR, PS, TS, we will have symptoms. Then examination findings, what you should write for pulse, what you should write for apex beat, and what you should write for auscultation. And management for all the valvular heart diseases, if you can't write about pharmacotherapy and all, just write about definitive management, valve replacement. That's more than adequate. So with that, you will be able to squeeze 5 or 6 marks minimum comfortably for a 10-mark question. And if you remember more precisely, if you can sketch the phonocardiographic image of the murmur and all, you will squeeze in 1 or 2 marks more. So you don't have to do a very detailed study of valvular heart diseases to be able to write questions on valvular heart disease. These two and the table that I shared tomorrow, that's more than enough. Okay. After that, from cardiology, the other cases that are expected for bedside as well as a question in neuro is heart failure, cardiomyopathies, hypertension, and ischemic heart disease, right? So these questions we will discuss tomorrow. So that's it from me today. The notes will be shared with all of you on the Telegram channel. I will tell them to expedite if any of the note is not shared so far. See, presystolic accentuation is because of active filling or atrial contraction. In atrial fibrillation, atria does not contract. So if it is not contracting, it is not creating more turbulence across the mitral valve. So more turbulence is not there, means accentuation of the murmur will not be there. So that's it from me guys today. Tomorrow I'll see you again. Tomorrow we'll continue the cardiology. Tomorrow's job is learning the table for other valvular heart diseases, heart failure, cardiomyopathy, and ischemic heart disease. Once you're done with that, you're kind of prepared to face all the major questions from cardiology. Minor things you can read from the Farre notes available. Right? See you tomorrow. Till then, have a good time.